Hello, everyone, and welcome to the April issue of DermSurgery Digest. I am Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. This month, we are excited to premiere our updated format, which will separate the cosmetic portion of the Dermatologic Surgery Journal into two 30-minute episodes. This episode, which we are calling Spotlight, will feature in-depth summaries and discussion on a few articles chosen by the feature editors. The second episode, Rapid Clinical Pearls, will cover the remainder of the journal, with the editors briefly covering clinical application of the data from each article. Our goal with this change is to make the content more digestible, with a focus on clinical application and enhancing patient care. Our feature editors for April are Kyle Lauck with Cooper Hospital Rowan University, who will be providing the article summaries, and Catherine DiGiorgio with CMD Dermatology Laser and Aesthetics, who will be providing expert commentary. They have chosen a single-center, blinded, split-body, randomized clinical trial of high-intensity parallel ultrasound beams versus microfocused ultrasound with visualization for the treatment of upper inner arm skin laxity, laser and light-based therapies for treating melasma, an in-depth review, and reviewing the role of angiosomes in filler-induced tissue necrosis, observed patterns and clinical signs for this Spotlight episode. Thank you for listening. We hope you enjoy this new format, and as always, have a happy surgery day.
Hi there. Welcome. This is this month's DermSurgery Digest Spotlight episode, where we highlight key articles for discussion from the April 2026 issue of Dermatologic Surgery. My name is Kyle Lauck. I'm the current Mohs Fellow at Cooper Hospital Rowan University. And today I'm here with this month's featured expert, Dr. Catherine DiGiorgio. Dr. DiGiorgio, would you mind introducing yourself to the audience?
Absolutely. Thanks, Kyle. So I'm Dr. Catherine DiGiorgio. I trained in dermatology down in New Orleans at LSU, and then I did a 2-year laser and cosmetic fellowship at Harvard Medical School, Mass General Hospital, and the Wellman Center for Photomedicine. And I'm currently in private practice on my own here in Boston in the Back Bay.
Awesome. I think you're going to bring some great experience to discussing these articles today. So in this episode, we are going to cover spotlighted articles related to cosmetic and general dermatology. So we'll get started with the first article here. All right, this is a single-center blinded split-body randomized clinical trial of high-intensity parallel ultrasound beams versus microfocused ultrasound with visualization for the treatment of upper inner arm skin laxity by primary author Jameson Loyal and senior author Mitch Goldman. So this month we begin our highlight section with the article I just named, and this documents upper arm skin laxity is a common and difficult to treat cosmetic concern. While brachioplasty remains gold standard, it is invasive and associated with scarring and downtime, which drives interest into non-invasive and energy-based alternatives. In this prospective single-center blinded split-body randomized controlled trial, 15 women aged 35 to 70 with moderate to severe upper arm laxity were enrolled. Each subject served as their own control, receiving high-intensity ultrasound and in one arm, and then microfocused ultrasound with visualization on the contralateral arm. Patients underwent a single treatment session were evaluated at 30 and 90 days. Primary endpoints were validated arm laxity grading scale, objective measurements of arm diameter and circumference, and the physician global aesthetic improvement scale, all assessed by a blinded evaluator. Both HIUS and MFUV demonstrated statistically significant improvement in skin laxity scores by day 90. The majority of patients showed at least 1 point of improvement. However, no significant changes were observed in arm circumference or diameter, and importantly, there were no statistically significant differences between the two treatment groups across physician assessments. From a safety standpoint, no adverse events were reported, and one key distinction was the efficiency, where HIUS treatments were significantly faster, averaging about 23 minutes compared with 35 minutes for MFUV. So to conclude, HIUS and MFUV appear to be safe and effective options for improving upper skin laxity with comparable clinical outcomes. However, high-intensity ultrasound may offer a meaningful advantage from the standpoint of treatment efficacy, which could be particularly relevant in high-volume cosmetic practices. Okay, Dr. DiGiorgio, I thought this was interesting. We have this randomized split-body trial. I feel like these situations do offer a unique controlled setting to compare some of these similar treatment modalities. I was wondering what your thoughts were on their approach and the methodology here.
I think this is a well-executed study. It's nice to have a control and a split body study evaluating two different modalities. Just there's just one portion where it seems like perhaps one of the subjects or a number of the subjects didn't complete both arms of the study. So just like for the reader to always kind of when they read a paper, just take a look at what the data shows. And so in the evaluator rating section, it kind of lumps them into subjects treated with microfocused ultrasound, making it seem like perhaps there were a different subset of subjects. However, I do not think that is the case because with the statistical data, it does show that was a split body study. So just for the reader to always kind of read things critically when they're assessing journal articles.
Yeah, and I had heard so there are two protocols that are used in practice with these high intensity ultrasound modalities, and I was wondering if you could speak to your experience with them and what you thought about their approach here in regards to settings and the protocol used.
Yeah, I think it makes sense that the results that were found in the study, it completely makes sense to me. I've used both devices, both the microfocused ultrasound with visualization as well as the high intensity parallel beam ultrasound device. I would say it's curious because with the high intensity parallel beam ultrasound device, there are a couple different protocols that at least I use in practice. There's one protocol where you kind of select the number of passes in the area. So for example, if someone's treating like the entire arm or, one cheek, you would pass the entire area multiple times, depending on the age and the extent of the laxity in the patient. You may do, fewer passes in a younger patient versus more passes in an older patient. There's a second protocol that is also used, which is called the treat to total energy. So this is delivering an amount of energy in a 3x3 centimeter square, and it's meant to decrease the surface area that you're treating. So rather than treating the entire surface area of the arm, you're maybe doing 3 3x3 centimeter rather boxes. So it decreases the duration of the procedure, and you're still achieving the desired outcomes because you're reaching that total energy required and measured, that's been studied, measured to have therapeutic effect. So I'm not sure which protocol they used. I find I do a combination of the protocols. I don't stick to one. So sometimes I'll use the treat to total energy protocol and the kind of passes protocol in a single area. So for the arms, I tend to do the treat to total energy protocol, however, but I don't think there's a wrong way.
Okay. Is there any strategy that kind of drives you to do a particular protocol with a given patient, or are there reasons that you do that?
I tend to do, so for facial treatments, I tend to do the treat to total energy in the submental area because I feel like this area is very bothersome to patients. And then I kind of do the passes in other areas. In the cheeks, towards the end of a treatment, I'll sort of vector in areas where I want more lifting, and then for the arms, it's more practical, to be honest, to do the treat to total energy, I think. So that's the way that I do those, the off face areas.
No, I really appreciate you taking the time to explain these settings and how you approach it, because I feel like, we read about these new modalities, but the details and the settings are often something that is kind of hidden behind a closed wall, it seems sometimes. And so it's very nice to hear how you use them in practice. Thank you. Maybe some other questions. So, upper arm laxity is one of those areas where patients often want improvement but are hesitant about surgery. In your practice, how do you position these non-invasive devices like MFUV or newer platforms like HIUS within the broader treatment algorithm when you're comparing it to surgery or biostimulatory injectables like Sculptra?
So I would say first and foremost, which we all sort of know, is the expectations of the patient. So if the patient is desiring an outcome that is more surgical and more definitive, then they're not a candidate for these non-invasive tissue tightening and lifting devices. So that's the first thing. So when a patient comes in and they hold their face up and they pull it all the way back, and it's just, you're not going to get them there with the non-invasive treatments. So, so that's the first thing. Secondarily, you know, younger patients are also on GLP-1s these days, and this has been a bit of a drive for these non-invasive tissue tightening devices, both microfocused ultrasound with visualization, as well as the high-intensity parallel beam array ultrasound device mentioned in this study. I find that the younger patients, they respond better. And so, so they sometimes may not need combination treatments, although, you know, I do offer combination treatments for the right candidates. And I do use the biostimulatory fillers. I tend to use a little bit more of the hyperdilute calcium hydroxylapatite filler for no other reason than that's just kind of how I do it. They're both great products. The hyperdilute polyalactic acid is also a great way to achieve, you know, a similar outcome to the hyperdilute calcium hydroxylapatite. And then when I combine these treatments for patients in general, they, you know, the microfocused ultrasound with visualization and the high intensity parallel beam device both have like minimal to no downtime. So usually patients will take advantage of that no downtime treatment and not combine it in the same day with a biostimulatory filler, which can result in, you know, bruising and, you know, redness and a little bit of downtime, particularly in areas like the neck and the arms. So I'll split those treatments up. My patients tend to be curious. They want to see what one thing's going to do, and then they'll wait and see, you know, what the other thing's going to do. So sometimes we'll space those treatments out just so that, you know, they can kind of gauge the results. So I think there's a great utility for these non-invasive treatments of all types because, you know, we didn't have these options before, and patients had to have surgery. And now we have an option where we can keep the skin young and stimulate collagen without having a surgical scar and slow down the process of aging a little bit. So, you know, they're great options in the right patient. That's the right candidate. And, you know, it's great that we have these options for the patients now.
Great additions to the armamentarium, and thank you for walking us through your algorithm. That's it's really helpful for approaching these patients that sometimes can have problems that this is a difficult area. So thank you. All right, next article is Laser and Light-Based Therapies for Treating Melasma, an in-depth review by primary author Zainab Ridha and senior author Mitch Goldman. So melasma is a chronic relapsing hyperpigmentation disorder that disproportionately affects women with darker Fitzpatrick types and carries significant psychosocial burden. Pathogenesis is multifactorial, involves melanocyte activation, dermal inflammation, and increasingly recognized vascular contributions, making treatment challenging. In this study, the authors performed a comprehensive literature review, analyzing data from randomized controlled trials, cohort studies, and case series evaluating laser and light-based therapies for melasma. The review highlights that while topical therapies remain foundational, energy-based devices can be important adjuncts targeting pigment and vascular components. Among these are IPL, Q-switched and YAG lasers, non-ablative fractional lasers, ablative fractional lasers, and picosecond lasers. Notably, low fluence Q-switched into YAG and picosecond 1064 lasers showed strong efficacy, particularly when they were combined with topical agents or tranexamic acid. Non-ablative fractional lasers offered fewer sessions and lower recurrence, while IPL and pulse dye laser provided additional benefit by addressing vascular contributions. Key challenges persist, mostly PIH, and especially in skin of color, and high recurrence rates across modalities. To conclude, these light and laser-based therapies are effective adjunctive treatments, but optimal outcomes do require multimodal therapy. Okay, Dr. DiGiorgio, I know as we jump in, listeners will probably be curious. What is your approach to melasma? Can you walk us through it a little bit?
Absolutely. Melasma, the most frustrating condition that we treat every day. So first of all, melasma is a chronic condition that I counsel patients. This is something that's never going to go away. So it's going to improve, and you'll have some good days and some bad days, usually clustered around the winter, unless someone's going to, you know, the beach and spending a week. They'll usually improve when they're in the less sunny months, and then they'll flare in the more summer months. So, you know, the first step is sunscreen. The good old fashioned stuff still works. So sunscreen and sun protection and sun avoidance. We do know the sun flares melasma, and some patients I also find that any type of heat flares melasma. So, if they're cooking a lot and they open the oven, sometimes it can flare their melasma. Secondarily, topical treatments using hydroquinone agents or other topicals like, Klingman formula, and those things. I think that those are a mainstay in the management of melasma. Oral tranexamic acid has been a great addition to the treatment options for melasma, and it works. I tend to reserve that for patients with melasma that does not improve with other modalities, with the topicals or with treatments that I will perform in office, or if someone has an event that they really need that melasma to be clear for, like their own wedding or that sort of thing. I'll start them on oral tranexamic acid. And then as far as in-office modalities, Vic Ross said it best, and he says, with melasma and skin that's prone to melasma, you have to go in there and make sure that the skin doesn't know that you were there. So anything that causes inflammation or heat, it has the potential to flare melasma. So aggressive and deep chemical peels can also flare melasma due to the inflammation that it causes. So I tend to select very light chemical peels using glycolic acid, and then low fluence, low density thulium 1927 has been effective for patients, and I'll do a series. I call it baby thulium. So I'll do lower energy, lower densities on those patients. And it's a journey. I don't treat them, in the summer. I tell them to save their money and come back in the fall when they're done with their sun exposure and be prepared that they will have flared, and we'll manage it then. So that's kind of how I approached it.
No, that is great. Thank you for walking us through that. I feel like this article covers a lot of different devices, and it seems like they do have some varying degrees of functionality. I'm curious, you said you start with the thulium. Are there any others that you do employ, or do you feel like that's primarily where you're getting your bang for your buck?
That's primarily, again, low energy, low density. So nothing with high settings here. And it does require multiple treatments. I have tried pico toning with a picosecond laser. I feel like it sometimes gets better, sometimes get worse. I do find, just in my experience, darker skinned patients do a little bit better with the pico toning than more Fitzpatrick skin types 1 to 2 or 3. Yeah, I tend to avoid IPL with melasma patients. And then the Q-switch laser treatments that they describe, it's a great paper. I mean, it's an in-depth review of all of the articles on melasma, which is nice to have everything in one place. But that's kind of been around for, at least 15 years. I remember when I was a resident, we were kind of trying it. We were pulling up papers back then. And I think if it was effective, people would be doing it. And I at least, in conversations with colleagues, that's not something that's being utilized.
Yeah.
But pulse dye laser, I do think, the vascular component of melasma is overlooked. It's not being overlooked anymore. I feel like there are more and more studies, as well as it's included in this study. And I do find that patients that have a vascular component to their melasma improves along with the vascular component, the hypervascularity, when you treat with a pulse dye laser, or you can use the KTP laser.
Okay. No, thank you. Thank you for taking us through that. So, an interesting thing you mentioned, I think, we with tranexamic acid, I think there's this kind of question, or topical or oral. And yeah, what role oral tranexamic acid plays in these patients, because I feel like it can be effective. I'm curious what your threshold is for employing oral therapy, and if you have any any medical indications that, or I guess contraindications that you're thinking about as you examine a patient in terms of being a candidate for that therapy.
I have a low threshold. It doesn't, I feel very comfortable prescribing it, especially at the low doses that we use for melasma. I do screen them, and make sure that they don't have a hypercoagulable state. you know, it's fairly uncommon, but they should be screened. And then, you know, I ask them if they're on oral contraceptives or other things like that, but that's not a contraindication for me. I will still prescribe it for those patients. And then just counseling them on the risks of use, and it's usually not an issue
Perfect.
or a concern, I suppose.
Yeah. Thank you. All right, we're going to move on to the final one. So this will be review and role of angiosomes in filler-induced tissue necrosis, observed patterns and clinical signs by Bridget Myers and Joel Cohen. So soft tissue filler use has expanded, and so has awareness of rare but devastating vascular complications, including tissue necrosis, blindness, stroke, and nerve injury. This article focuses on angiosomes, three-dimensional vascular territories supplied to a source artery, and explores how they can help to explain the location, spread, and clinical progression of filler-induced ischemia. In the article, the authors perform a narrative review using PubMed and Embase, examining literature on filler-induced vascular occlusion, angiosomes, perforasomes, choke vessels, and vascular anatomy, while also incorporating clinical expertise from high-volume cosmetic derm practices. The review highlights that filler-induced ischemia follows predictable livedoid or reticulated patterns that correspond to facial angiosome boundaries. The authors emphasize the role of choke vessels, which may spasm in response to intravascular filler and limit spread to adjacent territories, but at the same time worsen ischemia within the affected angiosome. In contrast, tour anastomoses may allow emboli to travel across territories and may explain why remote necrosis and even vision-threatening complications are a possibility. To conclude, a stronger understanding of facial angiosomes and vascular anatomy is essential not only for safer filler injection, but also for early recognition and more informed management for impending tissue necrosis. You know, I thought this paper was really interesting, Dr. DiGiorgio. Like, it's these angiosomes, this concept of how our vasculature can react to intraluminal filler. It kind of changes, I think, how I previously thought about filler injection. But I know that this idea may have been around for a little while. I'm curious what you thought about it.
I think this is a great explanation of it in this paper, and it's great to have this in the literature. I feel like, you know, with fillers, it's an illusion of safety. So anytime we're injecting the fillers, and this is what separates a board certified dermatologist that's trained and experienced, not only in performing the treatment, but also seeing the signs of a potential complication, and then going beyond that, knowing how to treat that complication. And this is what sets us apart, and why a board certified dermatologist should be performing these procedures, you know, always. You know, it doesn't change the way that I inject filler, because I find that it's an illusion of safety. And the article does mention this. You can have an occlusion, you can have a blindness with an injection in any area, you know, at any time. And this angiosome, you know, spasm stuff, it's scary. It's like we don't really know what's going on here still, with vascular occlusions, and whether it's actually filler occluding of a blood vessel, or a reaction of these angiosomes causing constriction.
Yeah, the concept of these like true anastomoses helping to explain like these remote necroses and blindness events is definitely a little sobering. You know, has this article, or has it influenced maybe how you would counsel patients or consent them, or can you explain what your current process is for context?
So I explained to patients that a vascular occlusion is a risk with any filler injection at any location, and that there are some areas that are of higher risk, you know, including the nasolabial fold, the glabella, the periocular area, the temple. But they're all high risk. I mean, it's a risk anywhere you inject. But patients are aware of that, and I explained to them that this can cause tissue necrosis, obviously in layman's terms. And then I say very, very uncommonly, it can lead to blindness and stroke. And I do explain the areas that are higher risk for blindness and stroke. And then there are some areas that personally I do not feel comfortable injecting, such as the forehead and the nose. I just don't, it's not worth worth the risk for an aesthetic procedure for me. Now there are plenty of experienced board certified dermatologists and colleagues that do inject those areas comfortably and safely. But I feel like the most important thing as well is developing your method. And so that's how you know how to anticipate complications and how to recognize them. Because if you do the same thing every single time and you perfect that method, that is how you become an expert.
Yeah. One of the very interesting things I found was this discussion with nitroglycerin, because it sort of has this paradoxical approach that they mentioned where you might relieve the vasospasm, but theoretically could allow emboli to spread across the angiosomes. Do you use nitroglycerin in your protocol at all? Do you have any current thoughts on its role right now?
So, so it's in the protocol because we all have the written protocol in the office, and everyone should have a written protocol, so that you always have those supplies on hand should you need to use them. And also, it's important to have the protocol so that everyone in the office and all the staff members are aware. It's in the written protocol, and I've had a vascular occlusion. If someone has not had one occur, then they're not doing enough filler. So it's awful. And it becomes very upsetting. And the particular instance that I'm thinking of, I did not use nitroglycerin. I flooded the area with hyaluronidase. It was probably within a couple hours after the initial filler injection. And then follow the patient for like 2 days afterwards to make sure that there was reperfusion. I suppose had the reperfusion not been clinically visible for this particular patient upon injection of hyaluronidase, I may have considered performing or applying the nitroglycerin. I do use warm compresses in those instances. So that's kind of just how I do it. But I think when something like that happens, you kind of throw everything at it. And I think as long as there's a protocol in place and that you have a ton of hyaluronidase in your office at all times, that's all you can do.
Yeah. One thing I am curious about that they mentioned a little bit, but is maybe becoming what's the word, and something that might be on the rise, the increase of this use of like ultrasound guided filler. And I think there was an article in DermSearch maybe a year or two ago that was by some colleagues that were not in dermatology that promoted this. But do you think these technologies like Doppler real-time imaging, do you see them like meaningfully reducing vascular complications, or kind of where do you feel like it sits fundamentally in terms of application for filler?
I think it's an illusion of safety. So you still can't see all the vessels. And then if the angiosomes contracting are contributing to certain cases of, tissue necrosis from, so to speak, vascular occlusion, if it's the angiosomes contracting, then it's not actually a substance occluding the vessel. It can happen regardless of whether or not you use an ultrasound. I think in order for the ultrasound devices to be a good tool, you'd have to become an expert in ultrasound technology, which that's like a whole fellowship in in radiology is ultrasound. So and you have to do it for every single patient, in theory, I think it sounds great, but I don't think it adds anything, to the safety, because if you get into a small vessel, you can't see that on ultrasound. So.
Yeah, no, what's the functional risk mitigation? And, I think this idea of angiosomes and the fact that we can get this distal blockage even when we're not in an adjacent vessel, it's just, yeah, it creates a lot of uncertainty. But, it's a nice reminder, like you said, I think, to bring it full circle, like it's why board certified dermatologists should be performing these procedures. And so with that, I think that will wrap up this episode. I wanted to thank you so much for your time today. This was so enjoyable.
Thank you.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.